I have no disclosures relevant to this content. But in my talk today, I'm going to go through a little bit very quickly about the incidence and prevalence of ovarian cancer, talk through some of the practical current management concerns regarding radical surgery, primary chemotherapy, and then talk through some of the improvements on standard therapy, including more extensive cytoreductive surgery, the use of intraperitoneal chemotherapy, weekly taxanes, neoadjuvant chemotherapy, and maintenance therapy. So in the United States, ovarian cancer is a relatively low incidence of new cases per year, but is the fifth most common cause of cancer-related death. Compared to other gynecologic cancers, ovarian cancer is roughly a quarter of the new cancers diagnosed and is responsible for about 50% of the annual cancer deaths. Ovarian cancer staging, it's roughly divided into 4 stages, with the vast majority of the patients with advanced ovarian cancer presenting with disseminated disease at the time of diagnosis. So our sample patient is a 75-year-old postmenopausal woman who's found to have a 4-centimeter pelvic mass on routine examination, some symptoms consistent with abdominal bloating and a CT scan that shows pelvic mass and what looks like carcinomatosis. Her CA-125 is markedly elevated, and on imaging, she's got evidence of a mental caking and a large pelvic mass. At the time of surgery, she's found to have widely disseminated disease, and this leads us to our first decision-making point, which is what do we do surgically regarding this? So practically thinking about how we manage advanced ovarian cancer, because at this point in time there are a lot of tools in our armamentarium and evidence to support a number of different approaches. So whether it's kind of initial primary cytoreductive surgery or neoadjuvant chemotherapy, I'm going to talk through a little bit of the rationale that I use to determine kind of which of those avenues we're going to choose first. But if we start with our kind of advanced ovarian cancer, the first question for me is whether or not she's a reasonably medically fit patient who's a candidate for an extensive cytoreductive surgery, since even with all the increasingly available information about neoadjuvant chemotherapy, still the single best reported outcomes have been in the patients who undergo primary cytoreduction. So if she's a candidate for a kind of, if necessary, extensive cytoreductive surgery, then the first step is to go for radical cytoreduction, with the goal really being the resection of all visible tumor. If that tumor is resected, whether or not the next step should be intraperitoneal chemotherapy or a combination of other therapies or a trial therapy is another controversial point, but still our best medical evidence at this point would be for IP chemotherapy after maximally cytoreductive surgery. If we're not able to resect all the visible tumor, then there doesn't seem to be an advantage to intraperitoneal therapy over IV chemotherapy. And if she's not a candidate for initial primary cytoreduction, whether it be for either age-related factors or medical contraindications, then we generally do favor 3 cycles of chemotherapy followed by interval cytoreduction, followed by additional chemotherapy. When we're talking through the kind of where we use surgery in advanced ovarian cancer, there's certainly a number of different time points where surgery may be relevant, and I think it's becoming a little more clear in the literature what each of these terms refer to. But for a long time there was a lot of mixing and matching about which terms referred to what. So in this talk, when we talk about primary surgery, we're talking about surgery that's done before any initial chemotherapy. Interval surgery, which would be surgery that's done after 1 to 3 courses of chemotherapy, of neoadjuvant chemotherapy. Second, look surgery is something that isn't really done anymore, but for a long time was popular in the treatment of this cancer, which was surgery at the completion of chemotherapy, either to confirm that all the disease was gone or to remove any residual disease at that point. And then secondary surgery is surgery that we perform for recurrent disease. The rationale for the last 40 years for primary surgery for ovarian cancer has been that the ultimate prognosis of these patients does seem to continue to be very linked to the amount of residual tumor left after primary cytoreduction, with 3 prognostic categories generally identified, those patients with no visible disease having the best prognosis. And this does continue to seem to matter. In most of the trials that are available of this cancer, we do kind of risk stratify based on the amount of tumor left at primary cytoreduction, and we do see improvements in clinical complete response, pathologic complete response, progression-free interval, median survival, and 10-year or longer survival, all linked to how much tumor was present after primary cytoreduction. So I'm going to go back a little bit and kind of talk through how we got to where we are right now. So this timeline really does kind of highlight a lot of the historical changes that led to the current treatment paradigm. And as you can see, unfortunately, this timeline ends at 2008, which we're almost really 10 years from at this point. And it's not that there haven't been any groundbreaking evidence in the last decade, but really we are operating very close to a standard that's been present for a long time. And part of that really is that we have a lot more work to do with the primary therapy of ovarian cancer, kind of to move the needle in terms of improvements in survival. So kind of going through this timeline somewhat, kind of around 2000 is when kind of we arrived at the standard of platinum and taxane, which was kind of Taxol and Carboplatin shown to have improvement over Taxol and Cisplatin with improved toxicity and quality of life. The GOG 178 demonstrated some improvement in disease-free survival with maintenance Taxol. And then the fourth of 4 randomized studies looking at intraperitoneal chemotherapy in 2008 confirmed IP therapy as kind of what should be seen as a standard, and there's been a lot of resistance to adopting IP therapy since that time, but really for the last decade we've been debating whether or not intraperitoneal therapy should continue to be used. Kind of looking at some of these changes sequentially, we see that certainly the median survival in advanced ovarian cancer has continued to increase over the course of the last 3 decades. We hope to see kind of additional improvement. Unfortunately, in the last decade since then, we haven't really been showing significant improvements in this median overall survival since that time, albeit there are some regimens now which may have less toxicity, but we haven't really improved median survival. Kind of had mentioned briefly this study before, but let's talk about more extensive surgery and how that may improve our outcomes. So I already mentioned that the goal of primary surgery is the resection of all visible tumor, and over the course of the last decade, there have been kind of increasingly radical procedures described to achieve this. Things like modified posterior exoneration, rectus sigmoid resection, multiple large bowel resections, extensive upper quadrant surgery. These are things that for the last 10 years have been accepted as reasonable evidence-based approaches to managing this cancer in a way that wasn't was done by very few providers before then. When I was in New York, we looked at a large series of patients that we had operated on there over time, comparing patients who had either presented with small volume disease, people who were radically cytoreduced to small volume disease, requiring extensive upper abdominal procedures to achieve this, and group 3 being the ones who were left suboptimal. And we found that the survival curves of the patients who had required extensive cytoreduction in order to achieve optimal disease status had a similar prognosis to the ones who presented with fairly easily resectable disease. And this and other studies at the time were ones that provided some of the impetus to continue pushing on with extensive radical surgery. Intraperitoneal chemotherapy kind of piggybacked well on that, because all the evidence showing benefit of intraperitoneal chemotherapy were in patients who had had optimum cytoreduction. And the GOG 172 study, published in in 2006, was the fourth of 4 randomized studies which showed improvement in IP therapy. This study looked at about 1,000 women randomized to either standard intravenous chemotherapy, which was, I guess, slightly different than the standard being Cisplatin rather than Carboplatin, to what at the time was a standard intraperitoneal regimen of intravenous Taxol, intraperitoneal Cisplatin, and intraperitoneal Taxol. The overall survival advantage of the intraperitoneal containing arm was 16 months, and this confirmed those earlier studies' findings. There was significant toxicity increase with the intraperitoneal therapy, and that has continued to be the case, but the survival advantage was not disputable. And looking back at the GOG 104 study, the GOG 114 study, and then the GOG 172 study, we can see that the median survivals in each of these cases were improved, yet still continued to be difficult to adopt this as a standard. So the National Cancer Institute in the United States had highlighted this. The toxicity with intraperitoneal chemotherapy is real. Certainly the presence of an IP catheter puts patients at higher risk for certain complications. The intraperitoneal administration of chemotherapy, even with dose reductions and additional therapy, does lead to more nausea, pain, and vomiting. And there's certainly greater hematologic, metabolic, and neurologic toxicity, which is not surprising given the fact that probably the efficacy of intraperitoneal chemotherapy is predicated somewhat on the ability to give a higher total dose. So can we do better without using intraperitoneal chemotherapy? Well, using weekly instead of every 3-week taxane has been another popular trend over the course of the last decade. The initial Japanese GOG 3016 trial looked at more than 300 women with advanced ovarian cancer, randomized to carboplatin plus weekly versus every 3-week taxane, showed a clear improvement in progression-free and overall survival, and then showed that the suboptimal patients were benefiting most. So there was more toxicity with the weekly taxane, but certainly improved survival advantage, and this was adopted widely by almost all the existing GOG studies at the time, which didn't necessarily confirm the Japanese GOG findings, but certainly didn't show that weekly Taxol had a worse prognosis. The agent that muddied the water somewhat in these studies was the incorporation of bevacizumab. In the GOG 262 study, certainly the progression-free survival was not significantly different if the patients received bevacizumab. There maybe was a slight improvement if patients did not receive bev. And in the MITO-7 study, looking at 800 women randomized to every 3-week versus weekly taxane in this combination, showed no difference in progression-free or overall survival. So when we're talking about neoadjuvant chemotherapy, we're talking about chemotherapy that we give before cytoreduction, and there certainly is it's been a long rationale for this method, making surgery less extensive, allowing more patients to be optimally cytoreduced. So certainly, seems to be a good rationale for treating this, and has certainly been adopted by our colleagues in colorectal surgery and other areas as a way to potentially make patients surgically resectable who wouldn't be otherwise. So what do we find in the ovarian, in the data we have about ovarian cancer? This is just highlighting a little bit what we've talked about before. So for those in the audience not familiar with the distinction here, primary cytoreduction is when we, at the time of diagnosis, patient undergoes radical surgery followed by chemotherapy. Neoadjuvant chemotherapy and interval cytoreduction would be a paradigm where the diagnosis is made, the patient receives several cycles of chemotherapy in an attempt to chemically cytoreduce their disease, then undergoes surgical cytoreduction followed by more chemotherapy. And the question that continues to be debated is, are these outcomes similar, or are there things that we change in the kind of ultimate outcome for this patient by exposing them to chemotherapy when there's larger volume disease? The rationale for primary surgery includes potentially improved response to chemotherapy, potentially improved survival, inarguably a higher morbidity associated with that. And the rationale for neoadjuvant chemotherapy is that there's certainly decreased morbidity. We may be able to select out certain women who don't respond to chemotherapy, and therefore we know are going to have a poor prognosis and may not need to undergo the necessary morbidity of surgery. And some studies have suggested possibly equivalent survival. So the main study that did that was the GCIG collaboration. Over the course of not quite 10 years, 14 European centers, more than 700 patients were randomized. The primary surgery versus 3 cycles of neoadjuvant chemotherapy followed by interval surgery and more chemotherapy. This was powered as a non-inferiority trial with a primary endpoint of overall survival. And secondary outcomes included progression-free survival, quality of life endpoint, and adverse events. Optimal cytoreduction was achieved in 42% of the patients undergoing primary surgery versus 81% of the patients who received neoadjuvant chemotherapy. And this is a little bit of a blunted statistic, since we, in general, have come to accept that really the goal of surgery after neoadjuvant chemotherapy shouldn't really be optimal cytoreduction. It should be resection of all remaining disease, since it's all chemo-resistant disease at that point. But the adverse events certainly were higher in the primary surgery arm. The hazard ratio did not favor one or the other, and complete resection of all macroscopic disease was found to be the strongest predictor of overall survival. But their conclusion was that neoadjuvant chemotherapy followed by interval cytoreduction was not inferior to primary surgery. But there were a number of criticisms at the time of these outcomes. The first was that the primary optimal cytoreduction rate was only 42%, and previous literature demonstrated that centers that are only able to optimally cytoreduce 40% or thereabouts of their patients generally had poorer outcomes. So people weren't particularly surprised when the median progression-free survival was only 12 months and the median overall survival was only 29 months, which for most of the GOG trials, these survivals were lower than most of the trials that were looking at just treatment of patients who were suboptimally cytoreduced only. There's some question as to whether second-line therapies were available to these patients, since there was substantial evidence at the time that there were second-line therapies that had survival advantage. So while a thought-provoking, interesting, and a study that certainly needed more definitive evidence to support, it was interesting and had not replaced the current standard in the United States initially. Over time, that's changed somewhat, and I would say that every year there are more and more practitioners in the United States using neoadjuvant chemotherapy. whether that's because of the rationale from this trial or because of kind of subsequent experience in patients or otherwise. But it certainly has continued to have an impact. And the second significant trial in this space was the Chorus trial, looking at more than 500 women in the UK with suspected advanced ovarian cancer randomized to primary surgery versus neoadjuvant chemotherapy. And compared to primary surgery, neoadjuvant chemotherapy resulted in a similar progression-free and overall survival. Because this was a UK study, nobody was particularly surprised by this, since cytoreduction to no visible disease was achieved in only a very low percentage of patients, and the low rate of kind of extensive surgery in the primary surgery arm made it difficult to evaluate this study. But certainly a well-organized study with good statistical power. Just some question as to the kind of attempted surgical cytoreduction. So maintenance therapy is therapy that just to clarify, maintenance therapy is therapy that at the completion of primary chemotherapy, if a patient is found to be in remission, maintenance therapy would be additional chemotherapy given at that time to try to decrease the risk for recurrence. Certainly a good physiologic rationale in ovarian cancer for maintenance therapy agents, and going on 3 decades now, has been an active area of study, which finally may have some teeth to it. So the GOG 118 study, which was published in 2011, was a large 3-arm study looking at almost 1,900 women randomized to what was considered primary therapy at the time with carboplatin and Taxane, both given IV, and then a maintenance placebo for up to 15 months afterward. Arm 2 were patients who received carbotaxol plus bevacizumab as primary therapy and then also received a maintenance placebo, and Arm 3 being patients who received carbotaxol bevacizumab and then up to 15 months of maintenance bevacizumab. The results were reported in an interesting way, meaning that the comparisons were kind of predefined as to how they were going to be reported, and as such, it was difficult to directly compare Arm 2 and 3, which ended up being the kind of two most interesting arms. But the results showed that women in Arm 3, so who'd gotten bevacizumab maintenance, had an improved median survival, or improved progression-free survival over the patients who had not received any bevacizumab, and that was statistically significant. Women in Arm 2 who had only received upfront bevacizumab did not have a significant increase in progression-free survival compared to Arm 1. Adverse event rate was not particularly high, but there was not a direct comparison of Arms 2 and 3, which was really an interesting question regarding whether bevacizumab in the primary setting made a significant difference, but certainly the recommendation for a new standard at that point was to include bevacizumab both as primary therapy and as to follow with maintenance therapy. The ICON 7 trial that was reported in 2015, again a large study looking at the same question, more than 1,500 women randomized to primary IV therapy followed by carbotaxol, bevacizumab, both as in primary therapy and as maintenance therapy. This study unfortunately did not show a difference in progression-free or overall survival. A predefined high-risk group, which included about a third of the patients, did have improved overall survival with bevacizumab, and these were patients primarily with stage 4 disease, inoperable stage 3 or suboptimal stage 3, with the rationale being that in these patients who are less likely to be candidates for extensive surgery, bevacizumab may have a continued benefit. So there are a lot of ongoing studies looking at new agents, looking at whether or not there are combinations of medications added to the standard Taxane carboplatin arm that can achieve similar outcomes without the toxicity of intraperitoneal chemotherapy. But in a lot of ways, we're not too far from where we were 10 years ago, with the exception of most of the patients newly diagnosed with ovarian cancer in the United States now are undergoing genetic testing initially for BRCA mutations, which I think has significantly improved our ability to predict who's going to respond well to therapy and to choose some more novel therapies in women who are BRCA positive. But still, for most of the patients with ovarian cancer, we're relying on aggressive cytoreduction at initial diagnosis. If patients are inoperable or have medical conditions that require some delay before it's safe to perform surgery, they're receiving neoadjuvant chemotherapy. The chemotherapy agents that we're using are still generally a backbone combination of platinum and taxane. Intraperitoneal therapy does continue to have some proponents, but is performed less commonly, I think, nationwide every year, and which agents are used intravenously and whether or not to include bevacizumab, again, is not a straightforward discussion. There's evidence certainly to support both sides, and the role of consolidation or maintenance therapy after primary chemotherapy continues to evolve. And the future involves a whole lot of other agents, many of which you're going to hear about today. And I guess we'll do questions at the end. Any questions right now? Yeah. Yep. Yeah. So I think HIPEC's been around for a long time, and the surgical oncology literature has somehow managed to exist for a decade and a half without real good randomized evidence that it's there, but a lot of expert opinion speaking to its benefit. I think from a standpoint of how chemotherapy generally works, it's hard to make a rationale that a single cycle of anything has a significant impact. But I think I think more. I think we need. It's certainly the recently published study is provocative. I think that even when we feel like we've studied something extensively previously, there's always kind of new ways to. I think we need to admit that kind of if studies are done well, then it's hard to argue with the data, and that it probably merits further exploration. But I think that I've given intraperitoneal chemotherapy in a kind of as part of a research trial when I was at a previous institution, and I think that the process of receiving HIPEC is not a. How many people in the audience have given patients heated intraperitoneal chemotherapy? Anybody? Couple, at least one or two. The getting these patients through their postoperative course is not a straightforward operation. There's lots of changes, physiologic changes that happen in response to heated intraperitoneal chemotherapy. Probably for low-grade tumors, there's a benefit from the heat rather than the chemotherapy component of it. But there's significant additional toxicity that goes along with that, which if there truly is a survival advantage, I think there's a good rationale for that. But I do think that it's not a therapy to tread into lightly, and I think it merits further study. But certainly the kind of recent evidence was provocative and somewhat unexpected given the kind of previous history of use of heated intraperitoneal chemo in ovarian cancer. So I look forward to either participating in trials to try to better establish that, or for more data from those investigators or others. Yeah. Sure. Sure. Yeah. Mm-hmm. And so your comparison arm would be patients who were resected and didn't get heated intraperitoneal chemotherapy? Yeah. So I guess the kind of the question to keep in mind would be, what is, if these are cases that are already done, what was your pre-selection bias for who got heated intraperitoneal chemotherapy versus not? Because there probably, is at least, a rationale as to who you decided to treat with that and not, whether they were, more likely to be able to talk. You need a relatively robust patient to be able to tolerate heated intraperitoneal chemotherapy and recover well. Certainly, in a lot of the previous case series, that was a, even if unstated, seemingly apparent selection bias in the patients who got heated IP chemo versus not, were ones that kind of people thought were going to be more likely to be able to recover from, the physiologic changes from getting that. So, but I think, far be it from me to throw out a new potential therapy for ovarian cancer without kind of enough data for it. So yeah, no, I'm excited to see any new evidence about heated IP chemo.
Also, I always ask myself, why would not progressing in treatment of ovarian cancer, why would not progressing for detecting the disease? For the last 20 years, we made small progress. Even the cause of the disease that I was asked many times in the clinic.
Yeah.
What is the cause? Like, other than a meal or diet, we only detect talent.
Sure.
To sell it in the state, a lot of research, a lot of fund. But again, incidence and the mortality almost the same for the last 20 years.
Absolutely. And I think, so in terms of causative factors or etiology for ovarian cancer, I think we're still, we still generally believe it's a kind of combination of the factors related to the field that the seed's being planted in, i.e., your genetic predisposition, kind of pre-existing mutations, kind of in the setting of what mutagen elements kind of work their way up kind of to the ovaries over the course of someone's life that kind of interact in those. So I don't think we've significantly move the needle there in terms of what causes ovarian cancer, although we're starting to get a better rationale for what are some of the genetic changes that can put women at higher risk. And we may get better at defining that high-risk population as time goes on. I think part of the dilemmas with diagnosing ovarian cancer early has always been the fact that because it's spreading as a surface disease and we're generally looking at serum changes when we're talking about screening, it takes a while to establish a vascular supply enough to really register serum changes. So it's not necessarily surprising that that people have widely metastatic disease before we start to see changes in serum concentration. Certainly there seem to be some suggestion that proteomics and other things would be able to detect kind of serum changes, early on, but that hasn't really proved to be a cost-effective way to screen for ovarian cancer. But I do think a lot of the rationale for why screening hasn't been more effective is that really when we talk about screening, we have imaging and serum blood tests. Kind of with subtle surface changes, we're not really our imaging isn't sensitive enough to pick that up, and it's not really kind of affordable to do that. And in terms of serum changes, you need a cancer that kind of is going to establish an early blood supply in order to see kind of a serum marker that's going to change early in the disease course. So I think that's, at least in my mind, still kind of why we haven't moved significantly in that arena, because what we really need is is a new technology. We need something that isn't necessarily looking at serum, but is looking at DNA or DNA level changes, epigenetic markers.
Okay, thank you very much.